Before I start, I wanted to share with you a bit of a media bite that I had this morning. A friend sent me a social media link, which I found quite disturbing, but I thought would be very relevant to you, that someone's come up with a way of rescuing the Australian economy. Some South Australian corporation is going to develop 3D printing for drugs and alcohol. South Australia is going to become the drugs and alcohol 3D printing service for the world. Forget uranium. We are now going to rescue our economy, and you are all going to have jobs for life. What do you think of that? The next email said it's the 1st of April, Malcolm. And then not long after that, our admin officer walked out, office manager walked in and handed me an envelope. Just paused at the door while I opened it, because I was getting my last lot of slides ready, and it had in there that it was her resignation. And for a split second, I believed her. So it's been one of those days. I had to get it off my chest, so now I feel much better. So I am going to talk about PTSD. Actually, I am traumatised, and I've had a lot to do with the veterans in Australia over the last 6 or so years. I actually did my psychiatry training mainly at the Repat Hospital. I was a Vietnam veteran moratorium attender and was greatly relieved when my number that did come out in the ballot meant that with the election of Gough Whitlam, I was no longer required to go to Vietnam as a medical officer. But 6 or 7 years later, I found myself treating people returning from Vietnam with post-traumatic stress disorder. So I had a bit of survivor guilt, you might say, which is one of the phenomena of PTSD. So and since then, I've been on a National Advisory Committee for the Veterans Counselling Service. So many of you might have had dealings with them in Adelaide. And in that capacity, I've been travelling across Australia, visiting all the veterans' sites, VVCS offices. And as part of that, we invite clients, patients to come in and tell their stories and say what's working, what's not working. And I've been absolutely amazed by the commitment and courage of so many people that do all these things on behalf of us. Some of the times we don't approve of what the government decides to do, but these people are actually doing it. So hence my link with PTSD and veterans, and I'm also part of my work with the veterans, or the Department of Veteran Affairs, we've been recently funded to develop PTSD education modules in the treatment of PTSD. So I'm very passionately interested in the links between PTSD, particularly older veterans or the older population, and drugs and alcohol. And I'm going to be talking about those things today. So people talk about anxiety as being a mixture of these sort of things, but for some of us, it actually feels like that. I mean, I don't know whether it was April Fool's Day when someone took that photograph. I said to them, "Excuse me, would you look around?" And they went, "No way. There's a shark behind you." Most people tend to have a bit of fear of sharks, don't we? We sort of almost innate. But that feeling is often described in 3 components, or the 3 systems model of anxiety, but it's our physiological and psychological response to anxiety. And with those 3 components, it actually helps you to understand nearly all of the anxiety disorders that develop, and then even the relationship between the use of alcohol and PTSD. And if you think of alcohol as a way of dampening arousal and actually probably assisting with emotional numbing, that's some of the cognitive components, but also those physiological arousal components, you can see why there's a very close link between the 2. Now, some of you are aware that the DSM, which has been very controversial, has changed some of the definitions and moved them in different areas. So the DSM-4 had a model, and now the DSM-5 has actually removed stress-related disorders under a separate category. And there's some other bits to it, but it's acute stress response and then PTSD itself. And one of the differences is a 1-month time frame difference. So with about 100 people going through a single traumatic event, say one sort of, building bursts into flame or something, about 80% of the population will experience some stress-related anxiety or symptoms over the subsequent days. By about a month, it's down to about 25%, and by about 3 months, it's down to about 15%. Now, that's as a general external event like an explosion. But what we now know is about PTSD is that the rates vary incredibly depending on the type of trauma and gender and a whole lot of other issues. So the definition is now, and you'll see in a minute, that prevalence rates have actually gone up in the 10 years between the National Survey in 1997 and 2007. I'll show you in a minute how the different change in the rates. And it's because the definition of PTSD changed to include witnessed or confronted with. So previously the trauma had to happen directly to you. So the idea now that a parent sees their child being run over or hears some terrible thing happen to their child is covered under these sort of criteria. So hence the actual diagnostic criteria has actually included more people. But the diagnosis is now 4 main components, which is the intrusive components, memories, reminders, flashbacks and nightmares or dreams, the avoidance behaviours that go along with that any trigger or situation that would remind us of the accident or the injury we tend to avoid, accompanied by anxiety or arousal symptoms. People classically talk about heightened, exaggerated startle responses or hypervigilance. So a noise or a bang of the door can really make people jump. And the newer part of the classification is about negative thoughts and moods, which is around things like survivor guilt and feelings of hopelessness and worthlessness. Numbness is a very important word there. There's a specifier, which means you can add on another component, which is dissociative phenomena. And one of the things I'm going to quickly touch on is about our work in the gambling area. So in DSM-5, one positive aspect from my point of view was that problematic gambling was moved from an impulse disorder into addictions. And to me, that felt right, and it was backed up by neuropsychological and genetic evidence to see if it fitted. But one of the links between PTSD and some of the other disorders is this dissociative phenomenon. And one of the bizarre things about pokies, or gambling machines, is that to us, I am the director of the statewide gambling therapy service, so a lot of our clients have comorbid gambling with other disorders. The idea that what people say to us is when I sit in front of that machine, I zone out. So I don't know whether it was deliberate. Part of me thinks it probably was. But part of the way the machine's designed is to help create that dissociative phenomenon. So what some people with PTSD do, so they go to a gaming venue and they get that relief. They get that feeling of being out of the normal life problems and stresses, and they zone out into what I would call the dissociative state. So there's various mechanisms by which PTSD might link to other disorders like gambling or alcohol. The last point on that slide is about the human agency. So this is where rates of PTSD are much higher when the trauma is perpetrated by someone. So in war, that's an obvious example. But someone you know is obviously much more relevant, particularly amongst women or everywhere in Australia, when you get domestic violence or sexual assaults, and then especially by somebody you know. So it's bad. The rates are high when it's a traumatic event by someone else. It's much higher when you know the person who's nearly killing you or raping you. So the prevalences that I put across there in the red is what I was really wanting to focus on, but particularly the links, and you sort of see the alcohol rates there, of lifetime prevalence and 12 months prevalence. So you can sort of see that overall anxiety disorders have become higher in the males. Sorry. No, I thought that was right, the females. And that is because of that link with the increased criteria, the raising of the bar in PTSD. And because we're talking about ageing and the ageing population, I just want to show these snapshots of the proportion of people with these disorders over time. And you can sort of see, obviously, it does get the symptoms or the prevalence rates decrease with age, which is a good thing in men and women. But it doesn't mean that for individual older men and women there are not severe and serious problems, and pokies and alcohol-related problems are part of that. So you kind of see this in more detail when you split that out to anxiety disorders and PTSD, that the lifetime prevalence is now 12% and the 12-month prevalence is about 6%. So that's pretty significant. So PTSD is the highest prevalence of all the anxiety disorders. And there's comorbidity between the anxiety disorders, but also with other conditions. So what's to add into that prevalence rate, and this is coming back to the veterans, Sandy McFarlane, who many of you will know, led what is probably one of the world's most rigorous epidemiological studies, which started with a pool of 27,000 current serving members in the Australian Armed Services, and over 3,000 people who achieved caseness on scores were then interviewed to get these sort of prevalence rates. So amongst serving members, so they haven't left the services yet, these rates are actually quite comparable to the Australian population. So in other words, even though a serving member is exposed to warlike service or situations, the prevalence rates actually end up, we still haven't followed them up to the rest of their lifetime, so lifetime prevalence is going to be lower than what it will be. But they're not that dissimilar. And even more remarkable, however, is that the alcohol rates are actually lower than the general Australian population. So we all are concerned and have been concerned about the links between alcohol, PTSD and particularly armed services. There was a huge national inquiry because of high suicide rates in the defence services, and there was a culture of alcohol use or abuse. And one of the really remarkable things I've noticed in the 6 years that I've been going around Australia with this reference group or advisory group is that on every visit, we visit one of the army bases or an Air Force base or something like that, and commanding officers are now including as part of their performance measures of their the people that they're responsible for, how they're managing mental health and destigmatising mental health in the armed services, and alcohol is part of that. So we're all filled with sort of scepticism, and sometimes what you hear on the media is often quite negative about the military and armed services, but they actually have made quite a significant advance, and that, I think, is probably one evidence-based example of that. When you look at traumatic events in general, nearly all of us probably in the room have had a traumatic event in our lifetime. And obviously, so the older you get, the more likely that is to happen, so 70-90%. A lot of this is a meta-analysis of prevalent studies, and you can sort of see that it is higher amongst people with military service, and there's also the issue in older adults of subclinical PTSD. So there seems to be a morphing or changing of the symptom profile with PTSD as you get older, but something that was initially 10 years ago regarded as probably some psychiatrist's anecdotal story has now been reinforced by evidence, is the phenomenon of delayed post-traumatic stress disorder. And the classic story is that somebody went to war, World War II or Vietnam, they came back, and the classic story of their family, and we hear this on a weekly basis when we go and talk to these families and the veterans, Dad worked his ass off. He wasn't home much, he was kind of a good dad, he was pretty harsh, he was a bit withdrawn, but things fell to bits when he retired. And then the emergence of actually formal PTSD symptoms happened. So this is still an evolving bit of evidence. But the subclinical symptoms of PTSD are actually really important. So when you follow people long enough and they've had exposure to deployment, as it's called, active service, it's the biggest predictor of PTSD is the person that has the closest proximity to the traumatic event. So the overall figures that came out of that PTSD ADF study was that overall, going on deployment was not a higher risk than not going on deployment. And that was a bit confusing to people. What it actually turned out to be that people in the armed forces were having as many traumatic events in Australia as they were when they went overseas. It was almost safer, this is bizarre, I don't mean this literally, to be on deployment than it was in Australia. And the reason is because people were going on training missions. And you've heard about the famous Black Hawk helicopter accidents and so forth. So there's a lot of accidents that happen in armed services. So it's not just about deployment, and it does explain why there's a whole range of PTSD that comes out in the armed services. So what about comorbidity? So there obviously is a high overlap or correlation or association between PTSD, drugs and alcohol, depression and other anxiety disorders. And the really interesting thing about physical health is that now we know that anxiety itself, and that's in any of those anxiety disorders, is now a precursor or a predictor of heart disease amongst other conditions. So it's has a biological impact. So depression and anxiety are now got pathways where people are showing links with inflammatory response. So having anxiety and depression can cause inflammatory responses that affect the health of our arteries and lead to cardiovascular disease. But now there's more emerging evidence about increasing rates of dementia. So why it's not always plain and simple for us as practitioners is that many people actually present to us with what we call psychosomatic symptoms. So whichever field of medicine or health we work in, whether it's psychiatry or drugs and alcohol or general practice, people don't walk in the door saying, I've got PTSD. So there's a really imperative there for us to be screening in different services for, if we're in drug and alcohol service, screening for anxiety disorders and gambling, and vice versa. And the typical complaints about headaches, aches and pains and so forth are probably the norm rather than the exception. Comorbid relationships between alcohol and PTSD, that Nicola Fear, who was here, interesting last name, in the area that she's interested in, was here about 2 weeks ago from the United Kingdom. She's summarised, or their team has summarised, a lot of studies around this. A bit of a bizarre range, 9.8 to 60%, but that note down the bottom that most of the rates are over 10% comorbidity. And that link between alcohol and PTSD is through the avoidance and hyperarousal components. And that makes clinical sense to me. We also have from the National Centre for, NDARP, the links with PTSD and people with heroin problems in high prevalence rates there. And in our gambling service, I've just pulled out a few figures to look at our rates of people, not with PTSD necessarily, but just in terms of the age proportion of people we're seeing present to our service. So if you talk about 65 plus, you've got 8%, but if you go sort of 50, you're sort of getting about a quarter to a third of all the people coming to us are in the older age group. And part of that is that people are sitting with or hanging on to their gambling disorders for a long time before they actually come for help. So we're seeing people too late. A lot of people are coming when they've lost everything. And to me, gambling has become a signal of other disorders. So there'll be the pre-existing grief, boredom, loneliness, depression, PTSD. So we see the problem gambling as part of a comprehensive mental health approach. We actually do focus on the gambling first. We think of treating the gambling disorder itself as a bit like detoxing someone from an alcohol problem. You can't really focus on the other associations or causes of the disorder until you've detoxed someone from their gambling disorder. So we'll assess, refer people on to other services if necessary, but we'll as soon as possible focus on treating the gambling condition itself. So the amount of money that people have spent is absolutely unbelievable. We've seen over the last 10 years 3 hotel owners or managers that have lost over $2 million from their own machines. So even though people are intelligent and aware of the tricks of gaming machines, people still get addicted. I just think of it as an addiction like any other addiction. And what one of the politicians from the Salisbury Elizabeth area came to see us and wanted to know how big a problem is this in my area. And we could pull out our figures showing the average loss of people from this area was $80,000. Now, to some of you that might not sound a fortune, but for people on low incomes, that's about 3 years worth, or 2 to 3 years worth of income. So the proportions are absolutely amazing. And people say, well, gambling disorder, it's their people's own fault. They don't have to gamble. And even if it does cause them a problem, as long as they get help, it's okay. And so I think, well, how does it compare to, say, schizophrenia or another, like a drug and alcohol problem? And it's got similarities with drug and alcohol problems in terms of the loss of the money. So it's compared to, let's say, non-drug and alcohol, where obviously money, dealing, etc. is a big part of it. But the amount of financial loss, which is the direct behavioural medium that we're talking about here, actually has devastating consequences for the entire family or people they work for. So the Productivity Commission came up with, for every problem gambler, at least 7 others are directly affected. So we're talking about 2 to 3% of the entire Australian population with a gambling disorder. So you multiply that by 7 in terms of those who are affected. So finishing off with treatment, I'm not going to spend long on this. There's really important 3 evidence-based interventions for PTSD, which the Centre for Post-Traumatic Mental Health in Australia, based in Melbourne, has developed the NHMRC guidelines and done the Cochrane reviews around this. And so that's where our contract was, to build online training and education in each of those 3 modules. Thank you. And I've just got some slides from people, our colleagues in Sydney, who developed a combined PTSD and alcohol treatment program. So the concern or anxiety has always been that you can't provide a psychological treatment or a PTSD treatment unless the person is already detoxed. So what they did was do a combined approach. So they had a 13-session standard kind of CBT approach, which included exposure for PTSD and cognitive restructuring and similarly motivational processes around the use of alcohol. I won't sort of touch on that. Achieved equal or better outcomes than a standard care group. In other words, it was partly about feasibility, let alone the outcomes. Could you actually do it? So in other words, they didn't get worse, but importantly, they had better improvement, higher improvement in PTSD symptoms than the treatment as usual group. So it is possible to combine these 2 treatments. So I'm not going to go through those in great detail. Our models are around the use of exposure and the use of cognitive therapy. And the reason I'm mentioning this is that we apply that same model in problem gambling as you would in PTSD. And if I'd had more time, there's a little video clip that I showed at the Addictions Conference a couple of weeks ago, where a patient went through our gambling therapy program. She got the idea of the whole exposure model, completely resolved a gambling problem. But Ben, the therapist, had been acknowledging, working with her on the alcohol problem. I forget how many, I think she was drinking about 2 bottles of wine a day. And she was sort of managing it and just sort of decreasing a bit through therapy. But as she got to the end of the therapy and came back for a 1-month review, that's right, she said, do you think I could use this same approach for my alcohol problem? And Ben just printed off Colin Drummond's 1994 paper on the use of exposure in alcohol, and she took it home, and a month later came back and said she'd sorted that out as well. So some of the cognitive and behavioural approaches are able to be applied across all of these disorders: alcohol, PTSD, gambling, and a whole range of conditions. So we don't need to kind of reinvent the wheel for a whole lot of these things. So the normal sort of CBT practice we would apply for any of these combined disorders, and no matter how old the person is, young to the elderly, co-therapists, exposure exercises, and at least 50% reduction in anxiety. There's a list of some of the resources I've mentioned, and I'm almost on time, probably, maybe. Thanks.